Hello, and welcome to our audience, both online now and those listening or watching the recording. Thank you so much for showing such great interest and enthusiasm. We hope to exceed your expectation. The goal of this series is simple: to provide from healthcare providers with both a halachic and hashkafic resource for medical-related ethics realities that arise. We are actively working on getting both Rabbanim and providers to participate in this series, and also welcome your feedback by private email or direct messaging. Rabbi Ausch is a Rav for many different organizations and has extensive experience as a paisik for complex medical shilas and fields phone calls from around the world. We are privileged and thankful to him for sharing with us today. Regarding questions or comments during the live presentation, there is a chat box. Please feel free to utilize it during this year, and Rabbi Ausch will have an opportunity to address them at the conclusion of this presentation or in a future presentation. We thank our first sponsor, Lily Cares, a hospice care network with facilities across the United States. A link to their website is included in the description of the video. Also, we thank all those who have provided guidance, assistance, and feedback towards making this a reality. With that, Rabbi Ausch.
Good evening, all. It is a profound honor to address such a distinguished audience of physicians, physician assistants, nurse practitioners, nurses, and other dedicated professionals who are integral to the healthcare field. We recognize that your work is driven not by monetary motives, but by a profound compassion and genuine commitment to alleviating pain and suffering in your patients. For this, we are deeply grateful. I'm personally thankful for the organizers of this meeting. It is long overdue, and it's our hope and belief that this series and the following coming series will enhance all of us on both sides of the aisle. This meeting provides to all a unique opportunity to engage in meaningful and informative discussions about various aspects of Halacha that naturally intersect with your vital work. Differences of opinion are inevitable, but it's through these differences, paired with mutual respect and understanding, that we find opportunities for growth and deeper appreciation of one another's perspectives. First, I would like to elaborate on how life is viewed from a Jewish perspective, particularly from the lens of Halacha. In contrast to the secular approach, modern medicine, as many of you know, is often rooted in a framework based on universal principles and population-wide considerations. While this approach is essential, it may not always address the religious sensitivities or spiritual frameworks that guide many patients. This gap can sometimes result in friction and or misunderstanding between doctor and patient, and even from patient to doctor. For example, the foundational medical principle of do no harm is a guiding tenet for all healthcare professionals. However, this principle can take on different nuances when viewed through the lens of Jewish thought. what constitutes harm in the secular medical world might not align with the Jewish understanding of harm. In addition, we view life with all hardships and pain as inherently valuable. We believe in prolonging life, irrespective of its quality, because every moment of life holds immense worth. As David HaMelech says in Tehillim, Yasor Yisrani Ka V'Leman Muves Loi Nesanuni. Though you, Hashem, have afflicted me with suffering, with pain, yet not giving me over to death. This reflects our core belief that even in the face of anguish and pain, life is a gift to be cherished. This perspective shapes our approach into life. It's our guiding principle, our motto, and the way we move forward despite our daily challenges. For this reason, even a life of suffering is still worth preserving and extending. Allow me to illustrate with a case I encountered last year. A Jewish couple had a baby born with ambiguous genitalia, which in Halacha it's called sort of androgynous, leading to extensive discussions between rabbis and doctors about how to approach this unfortunate situation. The parents wished to pursue a course of action to establish the baby's gender, believing it would prevent future challenges and suffering. One of the prominent doctors raised an ethical concern, arguing that such interventions might constitute harm, and suggested allowing the child to grow up and decide their gender identity later in life. While this perspective reflects a modern secular approach that emphasizes individual choice, it does not align with the Jewish view of harm in this context. From a halachic standpoint, the parent's decision was rooted in the belief that acting now would prevent greater emotional and social harm in the future. To help the doctor understand, I drew a parallel to the mitzvah of bris milah. In the secular world, some argue that circumcision, bris, is a form of harm imposed on a helpless infant. Yet in Jewish life, we see as one of the most profound mitzvahs, a defining act of covenant between a Jew and Hashem. The doctor paused, reflected, and acknowledged the profound nature of this perspective. His openness and willingness to engage with a different worldview demonstrated a true appreciation for the diversity of thought and belief within the Jewish nation. This interaction underscores a fundamental truth. While we may share one Jewish identity, our community is rich with diversity in culture, tradition, in lifestyle. From the way we dress to how we raise our children, from how we marry to how we approach end of life. Our differences are a testament to the vibrancy of our people. Yet, amidst the diversity, we are united by a shared faith and commitment to Hashem. This perspective, especially when applied to dedicated matters such as the end of life, is a reminder that our diversity is a strength, not a division. By understanding that these differences are a continuation of the varied ways in which we live our lives, it becomes easier to build bridges and collaboration. Bottom line is that a Jewish life is fundamentally different from a secular life. And even within the Jewish community, there are differing opinions on various halachic issues. Consider the experience of going through airport security. A TSA agent who has never encountered a talit, a tefillin before, might view them as a suspicious item. However, those who are trained and used to recognize these items understand their significance and handle the situation accordingly. The same principle applies to medicine. Professionals who are not well trained and not well knowledged in understanding the Jewish community and all groups of the Jewish community may view its members suspicious, uninformed, and unclear about their needs. However, once someone takes the time to learn and gain a deeper understanding, interactions become much smoother and much more effective. Let's turn our attention to the topic of DNI and DNR. DNI and DNR, as you know, stands for do not intubate, do not resuscitate. It is designed for terminally ill patients, but nowadays it's increasingly being offered to any elderly patient upon their arrival at the ED at a hospital. Additionally, private physicians may periodically ask the elderly patients about their code status, what they would prefer should they be brought into the hospital. As we mentioned earlier, terminal illness is a distinct entity when it comes to Jewish patients. And we strive to prolong it whenever and wherever possible. However, there are times when DNI and DNR is halachically appropriate. For example, in cases of end-stage cancer, where all treatments options have been exhausted, and it's clear that we have reached the final irreversible stage of life, or in cases of end-stage heart failure, this and similar situations may warrant DNI and DNR. Every day, we are approached with this kind of questions and shilas, while many are advised that DNI and DNR is appropriate. A growing concern has emerged. As highlighted in a lengthy article in the New York Times, I believe it was a couple of months ago, DNR orders are sometimes unofficially confused with DNT, do not treat. This practice has led to a distrust between families, rabbis, and the medical establishment, even when DNI and DNR is halachically permissible. Even more so, within the communities we are involved with, it is often the case that the elderly patient has no real understanding of what intubation entails or what resuscitation fully means. All they hear from the doctors are frightening descriptions, such as breaking ribs, living on machines, which understandably scare them. However, they do not realize that agreeing to these measures is in essence signing them off from life. Therefore, it's insufficient to rely solely on a brief conversation between the doctor and the patient to make such a critical decision. More care, context, guidance is needed to ensure the patient and their family fully and truly understand the implications of these choices. In most cases, what we advise families, who are usually very involved and are almost 24/7 at the bedside, it is that while DNI and DNR may be acceptable if necessary, it is best not to make it yet official, but at real time advise the team that we want DNI and or DNR. By doing so, we ensure that the continuation of care is maintained up to the last minute. I want to share with you a story I personally had to highlight this point. I had an 88-year-old Holocaust survivor patient. And when she was by her cardiologist one day, he asked her if she ever wanted to be dependent on machines. She said no. So the doctor made her sign a DNI, a DNR. One day, she was at home, developed a pneumonia, which led to respiratory distress. Family called Atzalo. A medic showed up, and his medical judgment told him that this lady needs intubation. The son mentioned that while there is no most forms at home, there is no official forms at home, but he recalls a conversation which the cardiologist had with his mother, where she said that she doesn't want machines, and she signed a DNI, DNR. And he feels that he can't go against his mother's wishes. The medic argued that it appears that this is an acute event, acute episode. She has a pneumonia. She can easily survive this episode. I don't see any justification not to intubate her. They agreed to seek my advice. It was a Shabbos. I was called on Shabbos. And after listening carefully what the medic told me, I told him, proceed with intubation. She was taken to the ED. She got broad spectrum antibiotics. After the 3 days, she was ready to be discharged. On her way home, her son had a schmooze with his mother. And he told his mother politely, I hope you're not mad on me. So she asked, why should I be mad on you? So he told her the story, what went on at the time the Tzula was called. I know that you didn't want to be on machines. So she asked him, which machines did I have? So the son tried to explain to her that, you were on a vent, which is a machine. The mother replied, that's not the machine I ever discussed with my doctor. You remember one day they took me into a tunnel. It was so claustrophobic. You remember that machine? That machine. And I'm telling you right now again, never ever should you put me again on this machine. What she meant was an MRI. She was traumatic from the previous years she had an MRI. Now, she never understood what her cardiologist spoke about machines. From her perspective, machines means one thing, an MRI. Now imagine this. The patient that assigned DNR, DNI, had we taken her DNR and DNI seriously to the full extent, she wouldn't be here anymore. Now let's discuss the concept of Chaya Olam and Chaya Shu. There's a concept of Chaya Olam versus Chaya Shu in Halacha. And there is a significant debate regarding what sets the stage for defining Chaya Olam. Some opinions define Chaya Olam those who are able to live from their diagnosis more than 6 months. Others rule that whoever can live more than 12 months is considered Chaya Olam, while some consider the ability to survive and recuperate from the present illness, regardless of the amount of months. Either way, this distinction has profound ramifications for halachic decisions in the medical field. For instance, should we pursue heroic measures for certain patients, or should we refrain? In making this decision, this distinction between Chaya Olam and Chaya Shu is always a critical consideration. However, I want to emphasize that when discussing Chaya Olam or Chaya Shu, whether it means 6 months, 12 months, when we look at the amount of months based on medical statistics, the reality is that our community often defies these statistical expectations. I'm actively involved, Baruch Hashem, in 17 prominent healthcare organizations. One of them is as the official Rav for Sunshine Children's Home. Sunshine Children's Home is located in upstate New York. The facility has 140 beds, exclusively for pediatric patients. Unfortunately, the majority of the children there are Yiddish Kinder. Many of them have severe conditions, genetic conditions, such as trisomy 13 and trisomy 18. As you may know, according to the medical literature, the vast majority of children with trisomy 13 or 18 have a life expectancy of less than 1 year. Yet, remarkably, we have many children there with these conditions who have they are now 1, 5, 6, and even 7 years, and a total, if I'm not mistaken, more than 11 children from trisomy 13 and 18 who outlived the statistic of 1 year. The reason we can contribute it that we as Jewish people are aggressive and we always seek out the best medical care, the best medical teams, the trials, wherever possible. You'll always find, at the top doctors, you'll always find Jewish patients. And that has an impact on the statistics, a positive impact. So just to raise the point, when we need to decide prognosis on medical statistics, we should always take in consideration the Jewish aspect as well. This example underscores an important point. While general statistics may paint a grim picture, Jewish patients often exceed those expectations. And we should always, as we said, take it in consideration. I want to take a minute or two to touch on a topic, a controversial topic of brain death. As we all know, there are conflicting opinions among various poskim as to whether brain death, or I should say neurological death, qualifies as a death from a halachic standpoint. The fact remains that most Orthodox poskim do not accept brain death as a valid definition of death. There are, however, others, though I wouldn't necessarily call them a minority, as I'm not going to count how many, but instead, which they consider neurological death as a means of death, just as cardiac death. But it's certainly, I can say it with all certainty, that the mainstream Orthodox poskim don't consider brain death as a means of death. That aside, a detailed analysis was recently released by an author in Cambridge, Massachusetts, who thoroughly explored the topic of brain death, and he presents evidence showing that the criteria and protocols used today to determine brain death are completely different from those used 30, 40 years ago when the topic of brain death started. This has significant implications, as even those poskim who once agreed that brain death should define death might not agree based on today's protocols. The author argues that the modern criteria do not meet standards of those earlier poskim. Let's not delve into debate for now. Let's assume that it is two opinions. We have two opinions. Some poskim consider brain death as a means of death, others oppose. What we must understand is that in addition to the halachic arguments, there are occasional stories, such in a recent case in Kentucky, where someone was declared brain dead and his organs were prepared for donation. But he later woke up. These stories, while I'm not going to say that this is the norm, reinforce the caution many halachic authorities maintain regarding brain death. The broader reality is that the majority of Orthodox poskim do not recognize brain death as a definition of death, while the medical establishment does. This is yet another area where friction, distrust, and arguments can arise. It is important to understand this dynamic. That said, while we always work with medical teams, always, there are three principles we cannot and will not compromise: oxygenation, hydration, and nutrition. Every patient must receive these three. Beyond these essentials, we are open to negotiation and discussion. I can personally attest that in almost every instance, when doctors are willing to engage in dialogue, we are able to find common ground. The point which I'm here to elaborate on. There was a guy who bought a lottery ticket. It was $17 million the price. And he was the lucky one. His ticket, his numbers were the lucky numbers. His friends, family around him were worried. How are we going to tell him such a big news without getting so overwhelmed that he'll lose it. So they took a therapist. The therapist went over to him and started schmoozing with him. In the middle of the conversation, the therapist started discussing the most recent big prize of the lottery. So that individual, the winner, responded, "Yes, I also bought a ticket." "Oh, you also bought a ticket. What are you going to do if you're going to find out that your numbers were the lucky numbers?" So the winner responded, "Look, I don't own my own home yet. I don't own my own car. I'll get a nice house, get a nice car." So the therapist told him, "But okay, we'll deduct a few million, but it's going to be a 10 million at least will still be left. What are you going to do?" So he was a good mood, the winner, by schmoozing from positive dreams. So he responded to the therapist, "You know what? 10 million, half will be yours." And the therapist fainted. He couldn't handle it. He wasn't prepared for that. It's a nice story. The point I'm trying to bring out: doctors, nurses, we're all trained how to help others, how to help people. But if we are not prepared ourselves how to handle these issues, then we might lose it. By listening, getting engaged in other opinions, to understand each other, to understand the patients, it's a win-win situation. The patient gets his best care, the doctor gets his best respect, which he deserves. So of course, we started touching some sensitive and delicate halachic related matters into medicine. We're going to continue the conversation. I want to conclude this session with what we have started. We greatly appreciate and respect the outstanding medical professionals who, as true shlichim from Hashem, work tirelessly to heal and bring comfort for their patients. May you continue with your noble and vital avodas hakodesh and be blessed with good health, success. And now I'll give the chance to respond to comments and questions. Thank you.
Thank you, Rabbi Ausch. One of the questions that has come up, one clarification of a DNR after the code has started. Seemingly, it's very difficult to stop the code, especially if the family isn't there 24/7. And where there's been questions about the possibility of there being we're stuck in limbo trying to administer life-saving care. While the patient is, and would tell them at that point that there's where the DNR is.
Right. So you'll be surprised. I get this shilas, 3:00 in the morning. They're working on my father. They're actively working on him, doing CPR. What do I tell him? So the way usually I'm asking, how long is the code going on? It's already 5 minutes. If it's 5 minutes, 2 more minutes, and then stop. When DNR and DNI is appropriate.
Okay, and let's say, what would be the guidance for if family's not present, right? So if, let's say, there's not a 24-hour visitation, or there would be a situation where the family is not actively present, how do we...
Right, so the same applies here. I always ask, so there's always someone there? If the answer is yes, I'll tell them what we mentioned before. Don't say DNR, DNI, and we'll deal with it in real time. However, if it's DNI and DNR acceptable from a halachic perspective and there's no one there for whatever reason, there's a small family, they can be, the patient is already like months in the hospital, they are exhausted already, they're not going to be there, I tell them you can do a DNR, DNI.
Okay, so to clarify, there are times where a DNR, DNI is appropriate and it's going to be in the hospital setting where the family is not there and it's not going to be communicated after the code has started.
Correct.
Question was, if the DNR was appropriate, where does the 2 minutes come from? What's the guidelines regarding the amount of time during a code?
So, very simple. Usually, we are dealing now with patients who should be in essence DNR, right? But unfortunately, for whatever reason, the family wasn't right there, and the patient coded, and they started the code. If by 5 to 7 minutes the code is not successful, it's just not going to go anywhere most of the time.
Aviva wanted to know, is patient's pulmonary status ever taken into consideration when talking about A&H, such as fluid overload?
Absolutely.
Okay. There was a question further up here. Oh. What about a patient who cannot eat and also can't get IV fluids because of terrible edema? So we said that the guidance was that we cannot withhold oxygen, we cannot withhold fluid, and we cannot withhold nutrition. So that's a question that was asked.
So right before this session, I was dealing with a case where his fluid overloaded already, and he has ascites in his abdomen, so there's a G-tube is not an option. So I told him, give him an NG tube. Give him an NG tube, slowly.
Okay. Is there any halachic issue for a Jewish medical provider to be around and do nothing when somebody is DNR, DNI, when technically he has the tools to save their life?
So when the patient should be DNR, DNI?
It's seemingly when the patient is already a DNR, DNI.
So if the patient is DNR, DNI, halachically DNR, DNI, it was consulted and it's halachically accepted DNR, DNI. So even if I would be there and I would know how to do CPR, I wouldn't do it.
There's another question further up. Do any of the children in that facility, somebody asked, do any of the children talk and feed themselves? And would it have any impact on the care that we provide them in regards to DNR, DNI?
What was the question?
If the children that have, let's say, trisomy 13, if
Right.
they are able to feed and talk themselves, and if not, does it have any implications on our medical decision-making regarding DNR, DNI?
If the patient is able to talk or not?
Talk and feed themselves.
No, this is not a criteria from a halachic standpoint.
By which point will a stage 4 cancer patient be a DNR or DNI?
So usually if the patient is still getting treatment,
Okay.
so even if it's a stage 4, if it's still, we can still prolong it, right? If we mentioned before, it's exhausted, no more treatment options, right? So we know that it's in the final stages of the disease and death is inevitable, then the DNI is a appropriate discussion.
Okay. The response was they're not halachically allowed to be in the DNR, DNI. However, they are still DNR, DNI, and then you're walking past the room and you have the tools to save them, and what would you do then?
So you're talking about a different, someone who should not be DNR, DNI, who should be full code, and for whatever reason they decided they want DNR, DNI, and now we have a Yiddish doctor there, and look, if that patient is going to be a separate discussion in the next series about, Lifna Ivair and those related questions, those related shalas, when should I, what I'm allowed to do as a medical physician, terminal extubation am I allowed to do, or I see a terminal extubation. Those related shalas will give a separate shear on, because it's more than just a short question and answer. So I would defer this to address specifically this on the next year.
Okay. Is it permitted to withhold nutrition in a patient on pressors and blood delivery if the brain is more essential than the gut? I understand.
That what?
Is it permitted to withhold nutrition in a patient that is on pressors?
So what does pressors have to do with nutrition?
And blood delivery is more essential than the gut. That's the question. If you're able to clarify that question. Is there any halachic issues with withdrawing care and treatment and DNR, DNI with non-Jews?
That's a part of the next year.
Okay. Any advice on how to treat the body after pronouncing? Is that it depends, it's different if it's a Jew or a non-Jew, but...
it's a difference, yes.
Okay. How do you know if a DNR was discussed with halachic authority? A lot of times it is signed and you don't know. So it would be in a situation where somebody is Jewish, they have a DNR, DNI, and the halacha is
It's not a medical practitioner's job to find out was the DNR, DNI discussed with halacha or not. If they see in the file DNR, DNI, they should follow the rules.
One second. I was asked at the beginning, can the Rav give a few minutes of advice to Hatzalah members who respond to those with DNRs, as well as those who perhaps the world would tend to think should have a DNR but don't? So end-of-life goals and discussions.
So, look, from one end, you mean Hatzalah member shows up where there's a MOLS form in place,
Yes.
right? So, and they feel that they should override the MOLS? What was the question?
Is there a specific guidance with how to deal with that? First responders that are coming.
So again, I don't think first responders are different in their obligation than we mentioned before with medical doctors. If a medical doctor comes into the room and there's a DNR, DNI in place, and he don't know anything, he don't know if it's halachic appropriate or not halachic appropriate, it was discussed with Arav, not discussed with Arav, he knows there's a DNR, DNI in place, he needs to follow the rules. DNR, DNI is DNR, DNI. When a Tzula member shows up to a patient and there's a MOLS form, it's not his role to now start with the family. Was this discussed with Arav, not discussed with Arav? The most he can say is, look, I think that the MOLS form is premature. I think that the patient should be, but I'll leave it up to you. It's not his role to fight and to, sort of force in his opinion as to override the MOLS.
Okay. In the Rav's opinion, is there ever a time when CPR is usher?
Of course, if the patients are actively dying, which in our criteria is agoisis, and you don't have any chance to take him out from the situation of the status of agoisis, you just taking agoisis, right, and doing nivul ames on him.
Okay. If the patient is full of cancer, including the abdomen, the doctor says nutrition will harm. Do you still need to provide nutrition?
So it's a card I encounter quite often. The doctor will tell me nutrition will harm. Usually, when I have a educated, mutual conversation with the patient, with the doctor, I can get the sense if it's real harm or it's just the ideology-driven harm by the doctor. You understand what I'm saying? Okay. So, if the patient is completely fluid overload and he can't even have an NG and there's a sinus in the abdomen, there's no way how we can safely give nutrition. We are here not to harm too.
Right.
We also have a do not harm. We are bound by the Torah do not harm. So, yes, there is what we spoke in this session. It should be noted. It's what you brought it up. What we spoke in this series and what we're going to speak in the future series is in general. Of course, every klal has a yotze min klal, as we say. Every general rule has an exception to the rule. But generally, those three should be given.
Okay. Is there a halachic issue with removing an NG tube from a non-Jewish patient who is going to hospice, which won't take a patient with an NG tube if it leaves them with no source of safe nutrition?
That will be Me'etz Hashem the next year.
Okay. If a patient is going to hospice, would the Rav feel the patient should still be giving ANH, or is there room for patient refusal for comfort reasons?
I would still advocate to give it.
Okay. If oxygen is something we can never withhold, in end-of-life situations at home when saturations are dropping, are we required to provide 100% oxygen non-rebreather? That brings technical difficulties with needing multiple oxygen tanks as they empty quickly. Is it enough to give them 10 liters of oxygen on a nasal cannula and allow just the sats to drop?
So for end-stage patient, which is obviously DNR, DNI, it's accepted.
Okay. For a geisis where CPR is usher, how does the Rav reconcile not agreeing to a DNR where CPR will therefore be initiated? Like a visitor will not be able to stop it from starting in the moment.
Excellent question. I'm aware of this, but we need to take, as we mentioned before, if we're going to establish the DNR, DNI, let's call it prematurely because it's going to be changed to a do not treat, we are doing more harm and we're expediting the demise of this patient than the goises issue. Okay. So I'll take that against the goises.
Okay. Do we need to go to the level of TPN to cover the nutrition, hydration, and oxygen halacha?
When there's no other means of nutrition, yes.
Okay. Waiting to see if there are any more questions. Okay, thank you so much, everybody. Oh, one last question. For a DNR on a trach and vent, do we give 100% oxygen when saturation is dropping?
Patient on a vent?
DNR on a trach and vent, do we give 100% oxygen?
I don't see any downside to it. It's not harming the patient at all.
Okay. Thank you so much, everybody, for your feedback. It's continued and welcome. And we will, Be'ezer Hashem, pick up where we left off, Be'ezer Hashem, next week. Any and all feedback is greatly appreciated. Thank you so much. Have a great night. Thank you, Rabbi Ausch.
Thank you. Thank you.